This is Richard Dykman. I'm with Dr. Bernstein in Diabetes University. This is the third video in our series of interview videos with Dr. Bernstein. Our first video was on what parents of type 1 diabetics need to know and is geared towards giving some information for parents when their children are diagnosed. The second video we did was on myths of diabetes, of which there are a lot, and I'll link the videos below. This video is a little bit more detail on the mechanics of diabetes management, and we decided we'd make a top 10 things that you need to know sort of outside the realm of food. Dr. Bernstein is mostly famous for his low-carb approach, which is a crucial and required element to getting normal blood sugars and avoiding diabetic complications. But there are also in the book a ton of insulin management and diabetes management techniques besides food, or related to food but not just low carb, that are absolutely critical and not all that well understood and well known. So we're going to go through those topics one by one with Dr. Bernstein. So thanks for doing the video, Dr. Bernstein.
Good to be here.
All right. Okay. We still need to talk about food a little bit. So the first important thing, your book talks about the 6-12-12. So it's a recommendation of about 6 grams or less of carbohydrate for breakfast, 12 for lunch, and 12 for dinner. But it's not just low carb, it's the type of carbohydrate. Can you comment on that a little bit?
Yes. First of all, the purpose of giving any carbohydrate to a creature who evolved as a meat eater, which is what humans are, is only to get phytochemicals and vitamins that our ancestors managed to scavenge out of what little vegetation they did eat. So the idea is to give you a little bit of vegetables to give you some of these phytochemicals that you might be able to get from vitamin pills, but I'm sure that vitamin pills do not cover every substance that you can get from vegetables. So what we do is take some very low carbohydrate vegetables, as varied as possible, and throw them into the meal plan. The reason for keeping the amounts low is because even low carbohydrate, slow acting vegetables like spinach or asparagus or celery, if you eat enough of it, your blood sugar will be greatly affected. So the game plan is to keep this way down, just to get a little bit of vitamins and phytochemicals. And I might add that the 6, 12, and 12 is for adults, and for kids it would be reduced in proportion to their size. And that's basically it. We want these very slow-acting vegetables. My book, Diabetes Solution, probably lists about 30 or 40 of these vegetables, and some of them I've never eaten. I don't even know what they look like, but they're very low in carbohydrate and slow acting. And that's basically it.
Okay, and the goal, I guess we should introduce the goal. When you do these things, what kind of blood sugars are you talking about?
Well, for adults, I'm trying to keep blood sugars pretty steady at 83 milligrams per deciliter, and for kids about 10 milligrams per deciliter lower, because if you look at non-diabetic healthy kids, not obese ones, you'll find that their blood sugars are in the 70s. So we want to match them. My philosophy all the time is that diabetics are entitled to the same blood sugars as non-diabetics. And that's possible with the tools that we have today.
Okay, so we get it. You can do vegetables as your carbohydrate to get the phytonutrients now. this brings us to our second topic, which is your plan in the book relies on protein foods, meat, fish, eggs, cheese, and so on. What tricks and tips do you have to designing a meal plan around fibrous vegetables and protein foods?
Well, basically, what we do is, if a patient comes in here, I'll ask them what protein foods they like, and we'll avoid those that they don't like. If they don't like red meat, I'll try to get them to eat a little bit so that we can get some vitamins that are sort of exclusive to meats, but that's not a major problem. There are ways of getting around that. But we find out, what proteins do you like? We then decide on the amount of protein. And I actually have plastic samples of protein that I show to people. And I'm going to show you my board of samples now. Okay, this I actually show to people in my office to give them an idea of sample sizes. There are fishes, chickens, beefs, etc. on the board. And I want to find out, how much can you eat and be satisfied but not feel stuffed? And they'll pick a size. By the way, something else I'll show them will be cans of tuna fish, a 6-ounce can and a 3 1/4-ounce can. Again, so that they can give me an idea of size. How many ounces? Well, we'll start off with the patient's guesstimate on how many ounces he'll be having at each meal. But before that, I will calculate how many ounces of protein he needs to survive, and if he's athletic, to build and maintain muscle. And there are guidelines that we start with that I use as a double check on the patient's estimate. For example, one guideline is that for a sedentary adult, you would have between 1 and 1.2 grams of protein per kilogram of ideal body weight. And sometimes what a person needs to not be hungry is much more than that. And we try not to make them hungry, so I'll up the amount. On the other hand, someone who's a professional athlete may need 5 grams of protein per kilogram of body weight. So we do some playing around with the numbers just to see if the patient's guess makes sense. And indeed, sometimes a patient will guess too much. More times they guess too high rather than too little. And we try them out and they end up not eating everything in their meals. So we initially make these guesses of protein based upon what a patient thinks they can handle. And then we limit the carbohydrate based upon my guidelines. So at breakfast, they can have up to 6 grams of vegetables in their eggs, but it's the same every day. And at lunch, they can have up to 12 grams of carbo in their salad, if they like salad, and they'll be having with it a protein food. And initially, we'll use the same protein food day after day. So if you decided you like eggs for breakfast, it'll be eggs every day. If you decide you like sausages, it's sausages every day. Eventually, when we get blood sugars really controlled and leveled off, we'll experiment. Will 1 ounce of protein in a sausage substituted for 1 egg, which is considered 1 ounce of protein, give you the same blood sugars? And if that turns out to be the case, then they're allowed to substitute 1 ounce of sausage for one egg, and so on. So down the road, the nature of the protein food can be changing. But remember that it's the weight of the protein that's important. So if you're trying to eyeball the amount, you have to be consistent. And a fistful of chopped steak is going to have a lot more protein than a fistful of fish, because the steak is heavier. So at least at the beginning, we have people weigh their protein portions until they're capable of eyeballing it. And then if we end up substituting one protein for another, we're substituting based on weight. There are other things to consider, especially with regard to the nature of your protein foods, when it comes to gastroparesis, which is a complication of diabetes that affects almost every type 1 diabetic who's been poorly controlled for more than 5 years. That's another subject altogether. It's extremely important, and it's almost totally ignored by the medical profession. So I think I answered that question.
Yeah, so on my list now, we have another important point, which is meal consistency and consistent amounts of protein. So why is it important for like my kid to keep about the same amount of protein per meal and per day?
The reason for being consistent with what you eat, is an effort to be consistent with your blood sugars. New patients come in here every month, and they bring blood sugar data, and they've read my book, and they know about the low carbohydrate diet. And why is my A1c still 6.5 when I know that a normal is between 4.2 and 4.6? And one of the most common problems is that they don't eat the same amount of each day. And they guess at the amount of insulin that it needs to eat today's amount of protein. To say nothing of the carbohydrate, just looking at the protein, you have to vary your insulin with the amount of protein. So if they're guessing at the amount of protein or changing it from one day to the next, they're guessing at the amount of insulin they're going to need. Who keeps a table of how much insulin I need for this weight of hamburger, this weight of fish, this weight of seafood, combined with this amount of salad, etc., etc.? You'd need a very lengthy table, and that you'd carry around with you, and you'd refer to it every time you eat a meal, and people aren't doing that. So by having the same amount of protein for a given meal every day, breakfast the same, lunch may be different from breakfast, but the same from day to day, etc., you get consistency, and then you get consistency of blood sugars. And the straight lines that you're seeing in these type 1 grit videos that many people are showing are only possible if you're eating consistently.
Mm-hmm. Okay. Next point is the importance of not cheating, meaning not eating a meal from time to time and high in carbohydrate. What can you say about that?
Well, that's a very good question, and I get questions from parents usually on my monthly teleseminar, what's the harm in once a week having a sweet dessert, or once a month having a sweet dessert, etc., etc. And to me, the fact that you're going to have a sporadic big increase in blood sugar is not the major problem. The major problem is the reinstitution of carbohydrate craving. Carbohydrate craving is an addiction. It's an addiction that didn't exist before high carbohydrate foods became available. But now that they're here and people are exposed to them, they become addicted to them and they have a craving. And as with other cravings, take cigarettes, you're off cigarettes for a year, you smoke one cigarette, you're hooked. And the same thing applies to carbohydrates. The classic example was a very good friend of mine who had lost 40 pounds, had lowered his A1c to normal, had reversed a very abnormal cardiac risk profile in a matter of a few months, and he was at a cocktail party, and there was a bowl of cheese tidbits with these little tiny cheese cracker squares, about 3/4 of an inch on a side.
Right.
He said to himself, if I have one of these, I can get away with it because I'm doing so great. I can taste one of these. By the end of the night, he had finished the whole bowl, and he never got back to his low-carbohydrate diet. We were not in touch. I only found this out years later. And after years of this, he ended up getting remaining fat and getting a coronary artery bypass graft. One cracker. So the hazard of exposure to carbohydrates is tremendous. He was not unique. He is typical.
Right. Okay, that rounds out the food portion. Now we're going to talk a little bit about insulin management. So you do something to manage your meal plan that most people are not familiar with. Most people, when they're diagnosed, are given rapid-acting insulin and huge amounts of carbohydrate food suggestions from their dietitians. And so when they read your book or they talk to someone following your plan, they've never even heard of what we call an R, or regular insulin. So can you talk about the importance of using R in your meal plan and in your plan to get normal blood sugars?
Okay. Type 1 diabetics, for the most part, at least in the USA, are using basal bolus insulin regimens. This means that they have a long-acting insulin that they take twice a day to cover the fasting state. If they're not eating, they still need a little bit of insulin all day long, and that's the basal insulin. To cover the glucose that comes in from meals, they need rapid-acting insulin. And there are several different classes of rapid-acting insulin with different action profiles. The slowest of these is regular insulin, which is true human insulin that's diluted 25-fold. And it starts typically, for the average person, it starts working about 40 minutes after an injection and continues working for 8 to 10 hours. But most of its action is during the first 4 or 5 hours. Now, if you're on a low-carbohydrate diet, this is just the timing you need for your insulin. You're matching the digestion of the carbohydrate and protein that you're eating. If you're on a very high carbohydrate diet, as the professional diabetes associations and endocrine associations recommend, then the logical thing is to take a faster-acting insulin. The faster-acting insulins are called Novolog and Humalog, and there's another that's sort of a little bit slower than those called Apidra. Now, in theory, these would work great, but the trouble is that these insulins have a sharp peak, and high carbohydrate foods, rapid-acting carbohydrates, have a sharp peak. And you're expected to match those two peaks in time. A near impossibility. Using the term near is even exaggerating, because it's a true impossibility, because the people who do this never match. They always go too high or too low after meals, and then may go too high or too low later on.
Right.
So it's impossible to make this kind of match where you're trying to take two peaks and match them.
Right.
What we're doing with regular insulin, low carbohydrate and protein, is taking a shallow hill,
Yes.
two shallow hills like this, and attempting to match them. And if you're a little bit off, you're not going to make a huge mistake. So your timing may be a little off, but you get, if it's off today, tomorrow you can adjust it by 5 minutes or so, and that might put you right on, because you're just matching up two shallow hills.
It's a very physics-based argument you're making. So even if these parents, I see a lot of discussion where a parent will be obsessed with a cupcake if it has 42 or 45 or 41 grams of carbohydrate. If only they could get the carb count correct. You're saying that carb counting doesn't work because of this analogy about these envelopes overlapping.
Right. You're dealing with mystical things when you think that being precise on counting carbohydrate is going to make up for the fact that you're trying to match a sharp peak with a sharp peak from insulin. It's not going to work. It's impossible.
Sometimes you'll go.
Here we have the insulin makers, the doctors, the dietitians, all pretending that the impossible not only is possible, but it's working every day. And that all these people with the rapidly varying blood sugars are well controlled.
Mm-hmm. Okay, so how do I use R? If I have, if I'm lucky enough to convince my endocrinologist to give me a prescription of R. By the way, R is available over the counter, right? And it's
in many states.
I think it's like $20 at Sam's Club. But how, suppose my kid eats a couple pieces of chicken, and his meal plan. How do you use the R?
Well, it's first of all, in his meal plan, he's not just getting a couple of pieces of chicken. He's getting a weighed amount or a reproducible amount that he's getting every day, and he's getting a reproducible amount of carbohydrate that's kept relatively low, and we'll start off with a guess as to how much regular to use for this meal. Now, I have formulas that I use that are fine for people who don't have insulin resistance. And the formulas are simple. A half unit of R covers 1 ounce of protein. And 1 unit of R covers about 8 grams of carbohydrate. Just let me think for a minute. Yeah, 1 unit of R, in theory, covers 8 grams of carbo, and a half unit of R covers 1 ounce of protein. So when you're starting your meal plan, your initial guess could be by doing the computations that I just made, and then maybe lowering it by 20% to play it safe, to be on the safe side. Chances are it'll be too low, but you see what happens to the blood sugars. And then you can increase the R the next day for those meals, a half unit per meal or a unit per meal, based upon how much you know that 1 unit will raise your blood sugar. Well, how do you know that? With a very obese individual who's insulin resistant, or someone who's pregnant, or a woman who's having her period next week, it's really a guess as to how much 1 unit will lower blood sugar. But for a person who's not obese, for a kid who's not in the middle of a growth spurt, someone who weighs, let's say, 150 pounds, 1 unit of insulin will lower them about 40. That's an initial guess. So here, after this meal, your blood sugar is running 40 higher than you would like it to be. The next time for that meal, you add 1 unit to the insulin. If you're running 20 higher, you add a half unit, etc. So it's plain and simple. The math is not complicated. Doctors don't want to even learn this. It's much easier to just take a lot of carbohydrate, a fast-acting insulin, and then close your eyes.
Right.
And throw the patient out there to take care of himself, or give him to a nurse educator or a dietitian and let them worry about it. And if you've looked at dietitians, most dietitians are overweight. Many of them are very obese. And many of them are diabetic. And those who are diabetic are frequently taking large doses of insulin to cover all the carbohydrate they're eating.
My experience with my kid, I'm going to advertise what you're saying is correct. The experience is that we have his basals correct. He wakes up in the morning with normal blood sugars, right around 80. He has his breakfast and he does his shot of R. And he goes to school, and now he has he'll test before lunch, maybe twice. And his line is flat all day until lunch. And then at lunch, he does another dose. He eats a breakfast and lunch that he loves. So he's comfortable with the food. And then he's flat until he comes home. So he loves this because he wants to play at recess. He doesn't want to report to the nurse's office with a blood sugar of 400. He doesn't want to feel bad all day. He wants to live his life. So the regimen that you're describing it's not a set it and forget it. He still has to do a finger prick and make sure. But if he needs to correct himself, he might do a half a tab of glucose, which he keeps in his pocket, not sucking down juice boxes in a severe state of hypoglycemia. And if for some reason his blood sugar runs high, he takes a little bit of insulin and he's back to normal. It's a totally different way of living your life. It's like our life has been restored as a family.
And it's unfortunate that neither the medical profession nor paramedical professionals nor industry is really interested in the patient. Outcomes like this are of no interest.
Yeah. Next tip. This is one I see a lot. People are given, diabetics are given basal insulins like Lantus and Levemir, and now there's Tresiba. And they're told to give a shot every morning or give a shot before bed. And 20 hours later, their blood sugar starts to go to the moon. Your book recommends splitting basal insulin. What does that mean?
Well, wait a second. What you just said was unclear to me. What you just said, sounded like what I recommend, which is to take your basal insulin on a rising in the morning and before going to bed.
No. Or.
I see. Okay.
Only one.
So yes, many doctors are advocating that you take these basal insulins once a day.
Yeah.
This was born of the ancient practice back in the 1930s and 40s of using protamine zinc insulin, which is a long-acting insulin, once a day, and then feeding the patient all day long, every couple of hours, to cover the insulin. It never worked. And along came a couple of insulin manufacturers, such as the manufacturer of Lantus, where they did clinical trials where they gave super doses of insulin, not basal doses. A basal means it's just enough to cover the fasting state and keep your blood sugar level without when you're not eating anything. What they did was they gave people enough insulin to put so much in one injection, in one spot in the body, that it would take over 24 hours for it to be fully absorbed. So they then showed that it was working for over 24 hours. If they gave a true basal amount that they didn't have to cover with food, that is, the people in this study had to eat to cover that insulin. If they were using true basal insulin, it would not have lasted 24 hours. Okay. In fact, what we find in practice is that if you take a basal amount of insulin, of Lantus or Levemir once a day, it doesn't last until the next morning. We also find that if you split it up to twice a day, which is what I do, and what I've been recommending since my first book, which was published in 1982, and I've been doing it on myself since something like 1970, you need it twice a day. It won't work if you don't take it twice a day. But what we're learning with the newer insulins, that unlike Ultralenti, which I used back in the old days, which lasted overnight, the newer insulins don't even last overnight. I have to, if I'm taking Levemir, I have to get up at 5 a.m. to take my morning shot. Mm-hmm. Otherwise, I'll awaken with a high blood sugar. And so we not only have the problem, A, that once a day is worthless, but even twice a day may not last you through to the next morning.
Right.
So I have to pee in the middle of the night, which gives me a chance to get my 5 a.m. shot. But if I weren't doing that, I would be using Tresiba insulin, which really lasts a long time. The manufacturers, again, distort the data. They say it lasts for 2 days. And what I find is it lasts overnight. So you can take Tresiba twice a day on a rising and at bedtime, and you don't need to take your morning shot of Tresiba at 5 a.m. You could take it when you wake up in the morning. Yeah. So this is very valuable new insulin. Trouble is getting insurance to pay for it.
Yes.
And also getting doctors to prescribe it because they don't understand it.
Yep. We have to do 3 Levemir shots a day. I can't get normal blood sugars without the third.
Okay, so and so you probably give a third shot of Levemir in the middle of the night. Yes. Am I correct?
Yep.
Yes.
Because the dawn phenomenon is just strong, right? So.
Right. Now there's a problem with small children and infants. The Levemir, the Tresiba, the Lantus cannot be diluted.
Okay, and that's our next subject, is diluting insulin. So,
okay, now 1 unit of regular insulin will lower my blood sugar by 60. So if my blood sugar is 110 and I want to get it down to 85,
right,
I would have to take something like a third of a unit, which is impossible to estimate. I could set my syringe at a half unit and come down by 30, and that'll be pretty close. But what if I only wanted to come down by 10 or 15?
Yeah.
It's a pretty hard thing to do. So what do? We dilute the insulin. Now, you can dilute regular insulin, you can dilute Novolog insulin, which is rapid. You can dilute Humalog, which is the most rapid. The diluted Humalog does not live as long as diluted regular. Diluted regular will last beyond the expiration date on the bottle. The diluted Humalog, it's hard for me to figure out how long it lasts, but I tell patients, throw it out after 2 months.
Okay.
You might be able to keep it in the refrigerator and it might last longer, but its life suffers from the dilution. And I don't use Humalog for bringing blood sugars down anyway, but it's possible to use it diluted because its rapid action still exists, and its super potency. I forgot to mention before that Humalog is twice as potent as regular.
Right.
Manufacturer doesn't tell you that, but because it's twice as potent, 1 unit will lower me 120. I can't possibly use undiluted Humalog to adjust my blood sugars. And no one can, except if they're very obese and insulin resistant. So if you're going to use it to adjust your blood sugars, diluted Humalog is a good solution, but you must throw it out every couple of months. Diluted regular is what I use, and I give it intramuscularly. So that works very fast. I get it to do most of its job in 2 hours.
Okay, we're going to talk about IM shots. It's worth reemphasizing. You made a point here, which some people might be surprised by, that when you, in your program here, you're correcting blood sugars at about 105 or 100, such as the control, and we do too. And that's the kind of control that that you can achieve. Most people would, on a high carb diet, would think that the 100 is the magic number to be at, but it's not. You can correct that kind of a number and get it down to normal again.
Right. By the way, I have to correct a mistake in my book. The book speaks of a target blood sugar of 83, but as I said earlier, kids run in the 70s, right. And the target for kids should be in the 70s. And I would say that would go up until after puberty and after most of their growth has stopped. Likewise, for pregnant women, after the first trimester, the blood sugars tend to run in the 60s. So pregnant women should be shooting for lower blood sugars.
But that's, again, another point worth, with a kid in your program, you can do that. The high carb program, the endocrinologists have their kids running 150 at night, 200 at night, because they're taking so much insulin, there's so much unpredictability. And according to some of your videos, I'll link them down here, the kids are going to get complications from that.
Right, and I see kids coming in after relatively short periods of diabetes with complications, including gastroparesis. And you know, these complications are not something that happen at random, like the JDRF used to tell us. It's a matter of luck. It's not a matter of luck. It's a matter of blood sugar. And you can prevent the complications totally.
Okay, back to diluting. Here's another problem I see. You have these almost infants being diagnosed, and
that's what I wanted to get on to next.
Okay.
How do you, since the basal insulins are not dilutable, the closest thing that we have that can be used for an infant or a small child is NPH insulin, which is an intermediate acting insulin. It's actually a mixture of regular and protamine zinc. And it sort of, in small doses, probably finishes working in about 10 hours, maybe 12 hours. And what I found with infants was that we had to use diluted NPH. You can dilute NPH, which is great. Diluted NPH, which you may have to give anywhere to from 3 to 6 times a day. I had one kid that I started treating when he was an infant, under 1 year, and he initially got NPH 6 times a day because the small, highly diluted doses just didn't last very long.
Right.
And it's a big strain on the parents to have to give insulin every 4 hours over and above what he got for meals. But it worked. And as he got older, we were able to spread out the NPH doses, and eventually he was able to go on to Levemir. Family's taking care of him without my... Actually, I found him a doctor, pediatrician, whom I taught. And he's doing a very good job with him. I hope he listens in on these seminars, because he'll learn about Tresiba, which this kid is ready for now.
And Tresiba, can it be diluted?
No,
okay.
That's what's unfortunate. And
so with the infants, what I see is that the endocrinologist gives the infant Lantus and Novo Rapid, and it's so strong that the kid has to eat 40, 60 grams, a 12-pound baby or 20-pound baby has to eat so much carbohydrate, their blood sugars are sustained 300s. What's going to happen?
It's obvious what's going to happen, and it's been happening for years. And the problem is that the people who write the rules don't care. There are other things that come first.
Okay, that's depressing. Next topic.
And that's why if any of the people who are watching us know any members of Congress or the Senate or powers that be in the government who have diabetes or have diabetic children, maybe we could get them on our side to try to change the ball game so that diabetics can live healthy and happier lives.
Mm-hmm. So next topic is how to treat lows.
I couldn't understand your word. It sounded like Moe's.
Lows. How to treat hypoglycemia. What is your recommendation for treating hypoglycemia?
Lows.
And what mistakes do you commonly see people making in the treatment of hypoglycemia?
Okay, well, the most common treatment, of course, is the classic treatment, which I'll never forget. I was at a JDF meeting. It was before there were JDRF, and the daughter of one of the directors was sitting there, and she would think she had a low blood sugar, and she had with her a quart of orange juice, and she would drink half or all of the quart of orange juice. And, well, she'd start off drinking a little, but of course it doesn't work fast enough, so she still feels shaky, she drinks more, and then she ends up with half or all of the quart, and then a few hours later, her blood sugars are up to 500. And this is in line with the sort of message that the American Diabetes Association perpetuates. They say they're now beginning to get interested in the use of glucose to treat hypoglycemia, but then they say, but you should also eat. So what should you eat? Have a peanut butter and jelly sandwich. People are using things other than glucose to treat low blood sugars. Glucose is the fastest acting stuff we have, and the fastest acting glucose is the liquid. Now, so ideally, one would use the liquid. The trouble is it's inconvenient to carry, and it's also expensive. So most people are not going to be using the liquid. But I would say if you're an athlete, you have to use the liquid because you're not going to be able to perform if your blood sugar is too low during a game. If you're driving a car, you have to use the liquid because if you're low and you continue to drive, you have a good chance of cracking up the car and maybe killing someone. So there are certain circumstances where liquids are mandatory. There are others where the tablets are adequate. You can buy glucose tablets in most drugstores. The trouble is that they're too large for small kids. The tablets contain 4 grams of glucose. Now, 1 gram will raise me by 8. A kid that's half my weight, 1 gram will raise him by 16. 4 grams will raise him by 64. So if his blood sugar is 60 and he wants to bring it up to 80, 4 grams is far too much. Mm-hmm. So what I have people do is cut these tablets in quarters in advance so they're each 1 gram. And then what you're carrying around is a bottle of 1 gram tablets. Mm-hmm. And there is no excuse for using anything other than pure glucose to treat hypoglycemia. You're asking for trouble if you do otherwise.
What about this 15 grams rule? Have you heard the 15 and 15?
Yeah, I've heard them say 15 grams of carbohydrate. Now, 1 gram will raise me 8. 15 grams will raise me by 120. A kid half my weight, 15 grams will raise him by 240. So this is a very nice way to trigger the up-down blood sugars that are so commonplace. You give them a large dose of insulin, you send them too low, you then give them 15 grams of carbohydrate, you send them too high, and I might add that if the 15 grams of carbohydrate is not pure glucose, you're going to have to wait for it to work, and since it's going to be relatively slow to work, you're going to get panicky, and you're going to eat more in the meanwhile. Mm-hmm. So
juice is going to be slow. Juice is going to be slow. A juice box is going to be slow.
Yes.
Okay. Okay, that's treating lows or hypoglycemia. What about hyperglycemia? What if you forget your shot or shoot an air bubble or one of the million things that might happen and you accidentally trigger a high blood sugar? What's the strategy there to get back down?
Okay. What I would do is take an intramuscular shot of regular. And if I need precise dosing, it would be diluted regular. However, you can also use diluted Humalog. Novolog is also okay. It's just not as fast as Humalog. So you could use diluted Humalog, diluted Novolog, diluted regular, and you could give them intramuscular, and it'll work real fast. But you have to be on top of it with measurements, and you also have to realize that some people do not have the muscles that I have. If I were to show my muscles, you'd see they're big and they're right near the surface. It's very easy for me to get into a muscle. Mm-hmm. So people may give themselves what they think is an intramuscular shot. They're going into fat, and it may take all day to work, or 5 hours to do most of its effect if it were diluted regular. And if we're diluted Humalog, it might take 4 hours to do most of its effect. So you have to make sure you get into a muscle. But there are other tricks. For example, you may recall that the ADA tells kids to give their shots in their legs, in the outside of their legs. Now, that's generally a mistake. Usually you're supposed to be injecting insulin into subcutaneous fat. And people do not have fat on the outside of their legs. And you look for a fat guy on the street, pay him $1 to feel the outside of his legs, and you'll feel that there's no fat. But there is muscle. And it's a great place for intramuscular injections if you want to get your blood sugar down fast. So you use the 12.7 millimeter needle, the longer needle, and you use some diluted regular or Novolog or Humalog, and you can get your blood sugar down real fast. The bulk of it occurring within 2 hours.
Okay. Is it? We have a video I'll link below. Is an IM shot painful?
Okay, very good question. Maybe yes, usually no. I find that 1 out of 20 or 30 IM shots that I give, whether I give them to me or to someone else, sooner or later I'll hit a blood vessel, and the blood vessels are surrounded by nerves, and that can be painful. And if they say it hurts, let's say I give it to myself and it hurts, I'll finish the shot fast, and I'll immediately press on the spot with my finger as hard as I can, because the fact that it hurt told me that I may have hit a blood vessel. It's not the blood vessel that hurts, it's the nerves around it. Okay. I may have hit a blood vessel. I don't want it bleeding under my skin, because it'll leave a lump, and that lump will initially hurt and eventually will be itching me for a couple of weeks. So I press on it and I don't get a lump. Press on it for about a minute. It also, if you do it through a thin shirt, stops you from bleeding onto the shirt. And that's rare. I said maybe 1 out of every 20 or 30 shots.
Okay. All right, we got 2 more topics and about 5 more minutes left. So another thing that I see in your book and I see online is has to do with this subject of injection sites. And in your book you say don't use thighs, which is an important point. Why is that?
Okay, well, for routine injections, non-intramuscular injections, as I just said, they're supposed to be subcutaneous. The basal insulin, you don't want working rapidly. And if you inject it into a muscle, it's going to work faster, defeating the whole purpose of long-acting basal insulin. The regular insulin for a meal, you want to last the length of the digestion time of the meal. You don't want to inject it into a muscle because it'll work faster than the food. This is one reason why we don't use Humalog for meals, because on a low carbohydrate meal, Humalog will work faster than the food, etc. So we use the outside of the thighs for intramuscular shots to get a blood sugar down fast. We do not use it for any other shot.
Okay. Last question.
By the way, this is diet root beer.
How is it?
Shoot the juice to me loose. Cook my goose.
What brand is that? It looks good.
Stewart's.
All right, I'll check that out. What about, last question, what about night checks? Should parents be doing night checks, or adults be doing night checks? Can you expect to sleep through the night with your program without making any checks at all?
Okay, that's a very good question. If you're a type 2 diabetic, not taking insulin, you don't have to worry about night checks. Assuming you're doing everything else according to my plans. But if you're a type 1 diabetic, there are still mistakes, plenty of places to make mistakes, and you want to avoid hypoglycemia, and you want to avoid a sudden high. I've had a situation, occurs rarely, maybe once a year, but it's happened, and one happened recently, where I gave an injection that was totally empty. And my blood sugar went sky high, and of course I had to catch it. And if that had occurred in the middle of the night, if my basal insulin were a shot of 0 volume, I would have to, number 1, make a correction, and number 2, possibly re-inject my basal insulin. Now, it happens that right now I'm using a pen, and it doesn't give false shots. I get a shot every time. But yes, there should be some way of checking if you're a type 1 diabetic. Now, I have, basically what I tell people is this: if you live alone, or even if you live with someone else, and they're not in your bed with you, and even if they're in your bed with you, if they don't wake up, if you've got the heavy breathing and cold sweat and tossing and turning of hypoglycemia, if they're not going to wake up, you've got to get a 24-hour glucose monitor, or you've got to set alarms to wake you up during the night. And I have all my type 1 diabetics who live alone or sleep alone using 24-hour glucose monitors. We want to catch the hypos.
Gotcha.
On rare occasions, you might catch a high, but usually it's the hypos that you're looking for. And there are plenty of places to make mistakes. And I might add further that if you have gastroparesis, you can end up with unpredictable highs or lows in the middle of the night. And most type 1s do have gastroparesis. Now, there's one special situation which involves people who are getting intravenous gamma globulin for common variable immune deficiency, which affects 25% of diabetics, and 10% of those get gamma globulin. That requires frequent blood sugar monitoring because they get some random return of beta cell function. That's a separate story altogether.
Right. Okay, that kind of wraps up our hour. Thanks for doing that. I'd like you to make one more comment now on what is the typical patient experience like before and after they go through the process of implementing your program. There's a lot of people watching this probably who are curious, and almost undoubtedly they're already following a high-carb diet, and maybe they're frustrated. What can they expect from the quality of life change, and what kind of comments can you make along those lines?
Okay, well, I have one patient whom were in the process of fine-tuning, who came from an Italian family, lived on pasta, developed her diabetes probably because of all the pasta, and she complains of the deprivation from not eating pasta.
Type 2 you're talking
Only,
about.
What?
It's type 2.
Type 2, yeah.
Yeah, okay.
She's the only one that I can remember in recent years, and even going back, way back to past years, I cannot remember anyone complaining about the diet after they felt so much better walking around with normal blood sugars.
Right.
You feel like you're alive, whereas with the high blood sugars or the up-down blood sugars of type 1s, you're always exhausted. And my experience is the same as those of my patients. I would come home from work long before I became a physician, and my wife would say, "You look terrible," and I'd say, "I feel all washed out." And that was life. And once I got my blood sugars controlled, that was gone. It was like being reborn. And people recognize that. And they feel better and they're grateful.
Okay, thanks for the hour.
Okay, my pleasure. Thanks for watching, everybody. This is Captain Video saying good night to all you video rangers out there on the airwaves.
Okay, bye.